You listen to this podcast because you like books, or maybe because you like learning, or maybe you just like the sound of my voice lulling you to sleep. If it's the first two, Audible has you covered. Too busy to read? Driving and don't want to run into another dog? Audible is a huge library of audiobooks where people read to you like you're a kid again. And guess what? You can try it out for free. Just go to readlearnlivepodcast.com/audible to sign up for your free trial today.
If there was one thing as a public health doctor that I would want to see happen in my professional lifetime is for our health system to identify these adverse childhood experiences in youth.
Hello and welcome to Read, Learn, Live, the podcast about improving yourself through literature. I'm your acclaimed host, John Monaster, and I'd like to welcome you to episode 10, also known as the We Made It to Double Digits episode. I wanted to extend a special thank you to everyone listening. Just this week, we passed 1,000 unique downloads, and I'm so glad to hear from people who have enjoyed the podcast so much. Feel free to tell a friend or three if you think they'd enjoy as well. Today, I'm delighted to have the opportunity to speak with Dr. Lloyd Sederer about his book, Improving Mental Health, 4 Secrets in Plain Sight. Dr. Lloyd Sederer is Chief Medical Officer of the New York State Office of Mental Health, the nation's largest state mental health system, adjunct professor at the Columbia Mailman School of Public Health, Sirius XM Insight Radio. He has published 7 books for professional audiences and 4 books for lay and student audiences, as well as 500 articles in medical and non-medical publications, including the New York Times, Wall Street Journal, Washington Post, Commonweal Magazine, and Psychology Today. I hope you enjoy our conversation as much as I did. Hello and welcome to Read, Learn, Live. This is John Monaster. I am here with Lloyd Sederer, author of Improving Mental Health, 4 Secrets in Plain Sight. Lloyd, say hello.
Good morning. I shouldn't say good morning.
You can say good.
Yeah.
You can say whatever you'd like.
Hello. Great to be here with you, John.
Thanks so much for joining us, and I'm so excited to talk about your book because I thought it was so insightful and so helpful.
Thank you.
So maybe just first start off with just briefly summarizing what the book's all about.
Well, maybe I can start by talking about how this book came to be, because I think it also helps to explain the book.
Yeah.
Every year, my wife and I go on a hike for about 7 to 10 days on an ancient pilgrimage trail that starts in France and goes through Spain. It's called the Santiago de Compostela Pilgrimage Trail. And in October 2015, we were walking on the trail for about a week or so, and you walk for about 8 hours a day, and you have a lot of time to yourself to think and to explore all kinds of things in your mind. And I had just read an even shorter book by a friend and colleague, Dr. Siddhartha Mukherjee, and Mukherjee had won a Pulitzer in 2011 for his 2010 book, The Emperor of All Maladies. And most of his books are massive. They're 500 pages or so, but this one was about 62 pages. And I had just read it, and it was called The Laws of Medicine. And it was more of a memoir than it actually was a scientific book, and he reflected on what were 3 counterintuitive ideas or laws that he had developed or come to in the course of largely as a young man in training and as an oncology resident. And I had read that, and I was walking and thinking, well, what's the analog for my field in psychiatry, mental health, and the addictions? Because this was about general medicine. And in very short order, I had come to 4 fundamental ideas, what some people call truths, and which I, in the end, called secrets, because they're so evident, but they're hiding in plain sight. And I had come to these, and I wrote down some notes on little pieces of paper over the course of just a couple days. and put them aside, and we continued on the hike. And then in December, a couple months later, I took a leave for 2 weeks from my work and wrote this book in 2 weeks, and it was like a gift. In that the ideas, which were very limited on pieces of notepaper, turned into a very ready flow of writing. And I wrote the book in 14 days, half a day each day, and what came out there was almost identical to the final publication. And I've never had that experience before. This is my 10th book. I've written a lot, and I don't labor that much, but this was effortless. It was if it was all there, and it was a great pleasure, and that's how the book came to be. And it means to offer the reader, whether that reader is a clinician like me, or a lay person, or a person affected by mental or addictive disorder, or their family, 4 ideas that are free, they're actionable, people can do something about them right now, and you don't have to call your insurance company for prior approval. That's how it came to be, and those are the 4 secrets hiding in plain sight.
Wow. That's a great origin story. I like it a lot. So you answered a couple of the questions about the writing process already that I like to ask. But one thing I really wanted to talk to you about was the idea of a short book. You mentioned your colleague had written a short book as well, and you specifically talk about in the beginning of the book that you wanted this to be short. So could you talk a little bit about the differences maybe between a short and a long book, and why you thought it was so important to you to have this book be short?
Well, I think, as you know, there's a famous line that if you want a long speech, I can give it to you in a short period of time. If you want a short speech, it'll take me a long time to make it. And over the years, as I've written for the general public, I've tried to concentrate and build a skill of writing concisely, and in language that is accessible, engageable to the general reader. And so I wanted to see if I could write a short book, not just a short blog or opinion piece, but rather a short a book, because also, like many people, I have stacks of books, 300, 400, 500 pages. I've read the first few chapters, put them aside into the pile of good intentions, and don't get back to them. So I wanted to also offer a book that somebody could actually finish.
Yeah. Sounds great, and that's exactly what you ended up with. It reads very easily. And maybe you don't have an answer for this, but did you feel like there was a hardest part to this? I like to ask that question, but was there anything particularly difficult? Besides, I understand it sort of flowed out very quickly, but during the whole process.
The more demanding part of the writing, which I had collected a variety of scientific papers on before I left for the writing leave, was the last secret, because it was built on much more of a science base.
What's the last one?
The last one is chronic stress is the enemy. And I felt like I needed to understand even better the science of inflammation in the body, of immunity in the body, and how that affects how long we live and how good a life we have. So there was more of a deep dive there into the science of our bodies, our physiology, our DNA. And before I could write that section and translate it in a way that would be understandable to anybody who was educated lay reader.
And while you were doing that, was there anything you learned that surprised you or that you hadn't already known?
No.
No, okay.
No, I understood it a lot better. But none of these secrets were new to me, and when I go around and speak about them, I ask the audience if I said anything new to you, and the answer is no. And even when I speak with my fellow clinicians, the answer is no. It's just that it's not something that has been more in the center of our concentration, the center of the screen, and in fact, it is the larger context by which we lead our lives and by which medicine is rendered.
Yeah, that's a really good point, I think, and maybe why the book is so powerful. So I want to get into the book itself because there's lots to talk about, and it's so interesting. And so the book really, it discusses these four fundamental ways that health practices can be improved. And the four secrets are: behavior serves a purpose, the power of attachment, less is more, and chronic stress is the enemy. How did you settle on these four in particular?
They were what came to mind when
Yeah.
I walked, and then I tried to think, are there more that would be valuable? I wasn't even that happy that there were four because the human mind tends to remember three things, sets of
Mm-hmm.
three things. A fourth thing puts extra burden on the reader, on the listener. But I felt like there was a quartet here and needed to be expressed, and so I didn't have more secrets. Though since then, a couple people have asked me, "Oh, if you write the fifth secret or the sixth secret, what might it be?" But I'm not going to tell you
No,
because they're secrets
that's
to be
right. That's
revealed.
right. For the next book. So you write that mental illness is a far greater affliction than cancer in terms of consequences. And I feel like many people might not see it that way or might not have thought about it that way until they read the book. So maybe you could talk a little bit about why that is. And I think the broader issue here is why people are sometimes reticent to discuss mental illness.
When I think about mental disorders, depression, anxiety disorders, PTSD, eating disorders, bipolar, schizophrenia, and the addictions, which are now headline news throughout our country and other countries, the prevalence, the existence of these conditions in Americans is much greater. They are much more common than cancer. And they're much more common than diabetes, for example, or hypertension. They are very common. In the course of a lifetime, 1 in 6 Americans will have a clinical depression. That's a very large impact. And these are conditions, when they're diagnosed properly, mean that somebody has been functionally impaired. It's not just they have a condition, but that condition impairs their relationships, their functioning. And and that's just depression, anxiety disorders, addictions. So you come to perhaps rates of 20 to 30% of the people, children and adults in this country, who are affected by conditions that impair their functioning and that are associated with real disability and high rates of suicide. So these are very consequential conditions, and that's why I made that statement. With all due respect to Dr. Mukherjee, who saw that statement and endorsed the book, but he recognized too, as he has written, because there are high rates of mental illness in his family.
Yeah, and one of the things I was thinking about is how people would be surprised by that statement. And I think people might be surprised by that statement because while there are a lot more mental health issues, it's not talked about as much. And it's something that is hidden a lot. And that's why I really think the book is wonderful, because it talks openly about things that often we don't. And I was curious why you thought that is and what we can do to fix that.
Yes, great question, John. There is this persistence of what we call stigma, discriminatory thinking and actions towards people with mental health conditions and addictions. It's worse for those people with addictions. They're more stigmatized. Yet, in the past 10 or 20 years, there have been many more people who have been public, particularly celebrities or others prominent, who get attention in the press, so that conditions like depression, or now with our veterans, PTSD, are more widely recognized and less stigmatized. But still, there is a very large and lingering stigma associated with these conditions. And part of the problem of the persistent stigma, as I see it, is that there are so many people with these conditions who are making a life. They're managing their illness, much like people with diabetes manage their illness or Parkinson's manage their illness. They're functioning, and they don't broadcast their problems for many reasons. One, they may be ashamed. Two, it may affect their standing at their work. Or they may just want to put some of this behind them. But for many reasons, those people, those large numbers of people who have these conditions and making a life, are not so evident. And what we actually see more of are those people who are disabled by these conditions, and we don't see how many people are affected or how well people can do when they get good treatment and they take good care of themselves.
So maybe the right way to think about it is we're probably walking amongst a much larger group of people that have these issues, but they've just managed to deal with them or are otherwise forced to deal with them.
Every time you walk into a room and you look around and there are more than 10 people, 1 in 10 of those people will have an active mental health condition at the time that you're with them. Not over the course of their lifetime, but at the time that you're with them, 1 in 10.
Yeah. So I want to turn and think about the 4 secrets now and talk through them all. So the first one is behavior serves a purpose. Could you just briefly summarize that secret?
Yes, this one I think is perhaps the most universal of all, because it extends not just to people with mental health problems or addictions, but to our friends, our relatives. And we see people doing things, or even ourselves doing things, that are perplexing. Why in the world is he or she doing that? It's not working for them. It's contrary to their health and their well-being, yet they persist in doing that. And that applies as much to our relatives as people with serious depression or even psychotic illness, where people act in very bizarre ways at times. And the message here is that, in fact, that behavior, as confounding as it may be, as perplexing as it may be, is serving that person in a particular way. Not in a very effective way, but the best way that they know. So, for example, people with addictions, very common condition. And we think, boy, this is destroying this person's life, destroying their relationships. They're losing their job. They're going economically bankrupt from this, yet they persist. And that is in the biology, actually, of addiction. What happens with addictions, particularly opioids and some of the amphetamine-like drugs like cocaine, methamphetamine, the brain's reward center, what gives us pleasure, what gives us reward, is pirated away by these drugs. And that, in fact, everyday interests, everyday rewards, whether they're relationships or work, diminish in their value, and that the principal reward is the drug itself. So that a person is taking these drugs for a purpose. They serve them, and the service that they provide varies over time. At first, it may be to get high, it may be to relieve emotional pain or physical pain, it may be to just escape the mundane. There's a purpose, but pretty soon, sometimes a matter of weeks, depends on the drug itself becomes the reason that somebody takes the drug. And what I mean by that is that not only is it their only reward, that as soon as the drug begins to wear off, they go into withdrawal. So someone is in a state of either intoxication or withdrawal all the time once they are hooked. And the hunger for the drug is driven by how unpleasant, sometimes how awful the withdrawal can be. So that's an example from the addictions where, and there's an old saying, it's actually from Japan, man takes a drink, drink takes the drink, drink takes the man. And it shows that same progression. So addiction is a good example. There are many others that I write about in the book.
Yeah, it's a great phrase to use to think through that. So you write that looking for meaning and communicating purpose in behaviors is often overlooked. And I thought for people that want to solve this, right, they don't want to overlook this anymore, what are some steps they can take to improve?
Yes, it's also a wonderful question. But I want to say what we typically do because it calls for a different response on our part. So I liken this a little bit to being in a foreign country and you're lost and you come onto somebody on the street and you say to them in English, how do I get to the train station? And they look at you and they're completely lost. They don't know what you're saying. And what is the next response from you or me? We say the same thing, only louder. And I think that's the MO for behaviors that confound us. We confront them. We blame people. We disdain people for these behaviors in the same, and we escalate. And once we raise our voice to somebody who's got an addiction or a family member with a problem, we're lost because then a battle ensues and no good comes of that. So it's more asking the person who is perplexed to pause, to take a deep breath, to wonder, perhaps this behavior is serving a purpose for that person, the person I love or the person I'm treating as a clinician. And what might that purpose be? And it's not for the person to answer that question, but to ask the kind of questions, non-judgmentally, that actually reveal the answer to that, which is, often, I notice that you do this. I bet you are very aware of this. Tell me more about it. And it's clear that this is very purposeful behavior. You engage in it with persistence. Help me understand that. What is this doing for you? Is it working for you? So there is a sequence here that is not rocket science, but it takes somebody to pause, reflect, and be more inquisitive than declarative.
So on that note, maybe you could speak a little bit about motivational interviewing and how that can be used.
Yes, most people don't know about that term. It's been around for decades, and it was a technique, a method that was developed particularly by Bill Miller and some others decades ago for people with addictions. And it takes the approach that somebody is having difficulty changing, and you're not going to exhort them into doing something different. So you want to try to get to their motivation. And you do that in the same manner that I just described, which is you form a relationship with somebody. As a doctor, let's say you have a patient who is a heavy smoker, and you know this is killing them. You could see this in terms of their health. And they even say from time to time they want to quit. And so the approach is, inquisitive. How many cigarettes are you smoking? And what are your thoughts about that? And maybe it's working for you. And most people who smoke, they say, as a rule, there's a lot of things that it's good for, it helps them with, and maybe that's fine. Non-judgmental, non-directive. Maybe that's fine. And maybe I don't need to say any more about this because this is what you want to do. And the curious thing about that actually is if you do that, the effect on the person that you're speaking with tends to be to stir the other side of the argument. So that rather than a doctor saying, you got to stop smoking, it's killing you, it's creating secondary smoke in your house, your kids, blah, blah, blah. Instead, you're raising the question that, well, maybe this is what they want to do. And in fact, part of them does. But when you present that, the effect is that often somebody will say, well, it's not such a great thing to be doing. That you will stir the other side of the ambivalence. And that's what part of what motivational interviewing is premised on, which is that all of our behaviors are ambivalently held. We want to do something, and we don't want to do something. So if we take the position that maybe you want to do this, often the retort will be, well, I'm not so sure about that. And then you can be more inquisitive. Well, tell me more about that. why would you want to quit?
So it's about having the other person sort of self-generate the idea that maybe it's not great.
Absolutely.
Yeah.
Yes. Yes. And the more that it comes out of the person whose behavior it is, the more likely there's going to be some action. And the other parts of motivational interviewing are then asking a person, why would you change? How would you change? Are you even ready to change at this point? Because there are what are called stages of change where people are not thinking about it, or they're thinking about it, but they're not ready to act. And so you're trying to assess somebody's readiness. And when they're ready, you're then asking them, well, what do you think you can do in the next week? What small steps can you take in the next week? So it's all incremental, and it's all driven by the person whose behaviors are at stake.
That makes sense. So I want to move on to the next of the four. Be sure we talk about them all. And the second secret is attachment is a human need and drive. Talk about that one for a minute.
Yes, this I call the power of attachment. And there are many examples of this. Two that I like to use are one that may be familiar to you and to many people. Remember when you were in psych class in college and you opened up the textbook and there was a picture of two side-by-side cages. And in one of the cages there was this surrogate monkey mother made of wood and wire. And in the next cage, that same wood and wire surrogate was covered with a cloth blankie, if you will. And Harry Harlow did a whole set of experiments with young infant rhesus macaque monkeys. He separated them very early from their mothers, subjecting them to maternal deprivation, which is a way to look at the power of attachment. And he did a number of experiments. For one of them, he raised some of the monkeys with just the wood and wire surrogate, and then he raised another set of monkeys with the cloth surrogate. And those that raised by the wood and wire monkeys proved to have very severe developmental problems. They huddled, they sucked their thumbs, they were fearful, they were asocial. Those raised in the cage with a cloth covered wire and wood, not a real heart-beating mother, they proceeded to have quite normal development. They explored, they ate, they socialized, they had sex. They were normal, and showing that even such a minimal level of attachment as would be provided by a cloth blankie was so powerful. And in one of to drive his point home, he gave another set of groups of monkeys, also deprived of their mothers, the choice between going to the wood and wire surrogate where there was food, or going to the cloth surrogate where there was no food. And they chose the cloth surrogate, demonstrating actually that attachment is more powerful than a basic drive like hunger. So that's primates, and you may say, well, that's pretty good, but those are monkeys, right? They're not humans. And the example there is perhaps even more definitive, because there's been a study that's been going on almost 80 years called the Harvard Study of Adult Development. You read about that in the book where I talk about that, and that's now being directed by a good friend, Bob Waldinger. George Valiant directed that. And in 1938, the study began by taking 268 Harvard undergraduate men. It was an all-male school, and these were men of privilege. And studying them, and now through 4 generations, thousands, women added later on. But the fundamental question of the study was, what makes for a long and healthy life? Something we're all kind of interested in, right?
Yep.
And you might think, well, these were privileged young men, so it was fame and fortune that predicted their having a long and healthy life. And not at all. Think some more. That in fact, it was having in their lives an enduring, trustworthy relationship someone whom they could turn to, that they would have confidence that that person would be there for them when they needed that person to be. And this has proved itself over and over again through now 4 generations, that the best predictor of a long and healthy life are relationships, the power of attachment.
Yeah, I really enjoyed that part of the book when you talked about that study, because I actually hadn't heard about it beforehand, and that's, yeah, really powerful. And one of the things you talk about within this section is the difference between secure and insecure attachments, which I hadn't really known about either. So maybe talk a little bit about the differences between those two, and some examples that we can kind of be on the lookout for, and maybe even how we should interact and work with people that are dealing with these different types of attachment issues.
There's been a lot of study, good, sophisticated study about attachment for about 100 years now. And then we know that some children don't have the kind of maternal, not that they're fully separated from their mothers, but they might be. They might be in foster care. They might have mothers who have addiction and are concentrated on getting high, not on their children. They may have neglectful mothers or grandmothers or abusive. That this doesn't allow for an early foundation in us, which is necessary, as exemplified in the monkeys, that whereby we have a feeling that there are people in our life who are whom we can securely form a relationship with. And if you don't have that early on, it's pretty hard to develop it. And sometimes if you don't have it for a long period of time, it becomes almost impossible because the damage can be so deep and so persistent. But most people have some level of insecure attachment that then affects their behavior. They can't form relationships. They can't even work very well because you need to have some sort of trust in coworkers and in your boss. So insecure attachment is a very powerful, bad experience that is no fault of the child. It's the consequences that the child is born into or raised with. And secure attachment is when, in fact, that feeling that there are people who love you, who want to be helpful to you, whom you can trust, are in your life. And that's the basic distinction between insecure and secure attachments. And for those of us who may have friends or colleagues or relatives or patients, in my case, who have insecure attachment, they bounce from one relationship to another. They don't trust that anybody is going to be useful or helpful to them, or they want to exploit people because they think that's the only way to get something from someone else. It is about understanding that this is their problem and this is how they're going to behave. It's nothing personal. That in fact they're driven by profound doubt that you have anything, you want to do anything of interest to them, that more you're out for yourself. So it starts with that, and it starts, and secure attachments can be built if the damage is not irrevocable. So it's more a matter of people learning over time that, in fact, not everybody is out to hurt them, not everybody is out to turn on them, but in fact, there are some people, selectively, not everybody, that they can turn to.
So something else you talk about in the chapter is domestic violence, and that you write that new and safe relationships and community are needed for a person to realize that respect and mutual gratification can be achieved here, and this can help them pursue a path away from violence. For someone listening that might know a victim or is a victim, how can they start building these new and safe relationships and community away from what's happening to them?
Yeah, great question. I think this takes us back to the first secret: behavior serves a purpose, because we will see, and I have seen, unfortunately, too many women, some men, some elders, who have been beaten and abused by their partners or their husbands, or boyfriends, siblings, and that they stick with this person, and you think, how can you do that? I mean, last time I saw you, you had bruises all over your face. Your arm was broken. You had to go to the hospital. How can you stay with someone like that? And that has to do with the degree to which they are attached in a early and faulty way to this person, and it's also a belief that no one else can be different or better, so that they are indeed suffering from insecure attachment and sticking with what meager needs they have met in this relationship. So it starts with recognizing that it's really hard for people to leave even abusive relationships because they provide something for them. So the work is about not just pointing out to somebody how much they've been hurt or abused. They know that. It's more a matter of saying that there are people who can be in your life, whom you can turn to, whom you can trust, that won't hurt you. And that's going to be very hard work for you to build that foundation, but you can.
Great. So the next secret I want to turn to is less is more. Talk about less is more for a minute.
Less is more is a secret that is so important for doctors, nurses, and patients, because there's a general view that if a little bit works, a bit more will work better, and a lot more will work a lot better. As a rule, that is not what happens. Actually, as you amplify the dose of whatever it is, medications, radiation, even psychotherapies, that more is lost than gained, and because of the side effects, both psychological and physical, from doing more. There's a long history which Mukherjee depicts in The Emperor of All Maladies of cancer treatment in the 60s and 70s, where discoveries were going left and right, radiation, chemotherapy, surgeries, and the well-intended doctors, they just kept escalating how much radiation, higher doses of radiation, higher doses of chemotherapy, more radical surgeries, until 10 or 20 years later they realized, boy, this is not helping, and in fact it's causing more suffering. And it's a very common behavior among my colleagues, doctors, particularly people who may have depression or psychotic mental illness like schizophrenia, bipolar illness, and they're not responding all that well. They're not having as robust a response as you might want from medications. And so the general thrust then is, well, let's try a higher dose, or let's add another medication. And over time, that becomes cumulative, and as generally, the doctor does not remove any medication or lower the dose of other medications when that happens, and nor does often the patient or family want that to happen, because they're concerned, well, he's not doing well, but he's doing better. And I'd be concerned if you pulled one of the building blocks of his treatment out, that he would do worse. So this cumulative effect, which I've seen again and again, and it's called polypharmacy in my field, which is the use of many medications, different classes, cumulative over time, that this is a very common practice in medicine, not just in my field, but in all specialties. And we need to stop and think then that maybe, in fact, less is more, that doing more of the same thing particular is not going to achieve better results.
So one of the first things you talk about within that section is the story of Susan Long and the concept of start low, go slow. Could you talk about her story and what Start Low, Go Slow is all about?
Yes, well, of course, it's a fictional name, but
Yeah.
it describes a patient that I had many, many years ago, and accomplished younger woman in her late 20s, I think, at that time, who had a very bad anxious depression. And it was really affecting her work. She thought that she might lose her job, and she was on a good career ladder, a professional woman. And she came to see me about this so that she could preserve her work and even build social relationships in a better way. But she was very impaired, and I talked to her about treatment, including medications and psychotherapy. And this was a time before Prozac, before the SSRIs, and there were two big classes of medication. One was called the tricyclics, which had a lot of side effects and weren't that good with anxious depression. And then there was another class called monoamine oxidase inhibitors, MAOIs. And I had used those a bit, was familiar with them, and I suggested that she try one of these medications, one of these monoamine oxidase inhibitors. And so she agreed, and we started, and I started her not on a high dose, but not on a low dose. And a few days later, I got a call from her saying, "Doctor, I'm calling you. I'm lying on the floor because I can't sit up. And I didn't go into work today." And I said, "What's the matter?" And she said, "Well, every time I sit up or stand up, I get so dizzy, I know I'm going to faint, so I'm lying here on the floor and not going into work." And I immediately recognized that this was a side effect of the medication. It's called postural hypotension, where when you change your posture, your blood pressure falls through the floor. And when that happens, you get dizzy, and you don't want to stand up. And I recognized that, and so I said, "Well, this is a clear side effect. It's completely reversible. Don't worry. And here's what we're going to do. We're going to have you hold on the medication for a few days so the blood levels go down. You're going to drink a lot of water with a little salt in it to drive your blood pressure up. And then we'll start again, if you want, at a much lower dose and increment up much more slowly. Start low, go slow." And it worked.
You wrote also that patients and doctors can sometimes be too into the newest, shiniest treatment and miss out on more cost-effective older options. So maybe talk about that a little bit, and then talk about how patients can work with their doctors now to ensure that that doesn't happen.
Thank you for asking that question, because one of my goals in writing this book was to impart to people with mental conditions, addictions, and their families that there is information that they can have that will make them stronger advocates for themselves, that when they show up in my office or another clinician's office, they'll have reliable, trustworthy information, and they'll have a lot more confidence in themselves about asserting or asking questions or asserting certain ideas with the doctor. So I wanted to, that was one of the reasons I wrote this book. And this is a good example because my colleagues, I don't mean to be critical, these are very well-intentioned doctors and nurses. They're just trying to do more. And they're recognize that particularly the biological treatments that we have today, all treatments that we have today, can be effective, but they're not as effective as we want. So when a new medication comes along, a new intervention comes along, it's one of the first things a doctor will grab onto for those people who are not doing as well as that doctor would desire. And so, and most of the medications that have been introduced, particularly in the past 10 or 20 years, are what are called Me Too drugs. They have the same mechanism of action in the brain. They're just newer and a lot more expensive. So some of the traditional antidepressants, some of the traditional medications used for bipolar disorder, like lithium, these tend to be neglected for more modern, shinier medications. And the other thing that's happened, I think quite unfortunately, I've been around long enough to see this, is that there has been a biological revolution in psychiatry, a much more belief in biological remedies, medications to be specific, primarily. And in fact, when that's because of the dominance of that idea and the dominance of it even in the training of young doctors, there's much more attention to medications and little attention to many other interventions, like psychotherapies, particularly cognitive psychotherapies. What I mean by that are helping people understand, problem solve, log their problems, recognize the triggers, recognize what they can do. There are people who have severe, persistent mental illness where their principal problems are not that they're hallucinating anymore, they may be, but rather they have impaired mental functioning. Their executive functions are impaired in terms, what I mean by that is concentration, short-term memory, sequencing, judgment. And there are now many effective techniques that actually enhance people's cognitive functioning. You've probably seen advertisements for this, Luminosity or something, where 15 minutes a day you can really sharpen your brain. But there are those that are much more customized. So there are many other interventions, getting families involved, educating families. I call this comprehensive treatment, not doing more of the same thing, but additive interventions that are non-toxic and that are much more apt to produce results.
So for patients that, or for their families, friends that are thinking about these things, how can they get themselves better educated? So when they show up at the doctor's office, they've got ideas about some alternate treatments that might be helpful as opposed to just the newest, shiniest drug.
Yeah, great question. I don't know if, as a patient or a family, you have to study the new medications and their mechanisms of action. I think it's more a position of saying, doctor, why did you choose this medication? And why did you choose, and tell me, what did you choose among? And why? And why did you choose this dose? And if it turns out also that the doctor is only prescribing a medication, then I would really urge these people to assert themselves, because one of the messages I hope people take from this book is that comprehensive treatment is much more effective than monolingual or monosyllabic single treatment. So they're in a position to say, well, I understand that medications are important, but aren't there other treatments that would help me or my loved one? What might those be? How might those work? How can I get those? How will that enhance my chances of success? It's more a matter of not being an expert, but being a strong advocate, an assertive advocate in the doctor's office.
Mm. That's a great takeaway. So the last secret is chronic stress is the enemy. Talk a little bit about that one.
Yeah, so I think I mentioned at the beginning I had to sharpen my my science knowledge to write about this. And one of the things I clearly learned again and again was that our bodies have two forms of inflammation. They have acute inflammation and they have chronic inflammation. And acute inflammation is a good thing. It's what happens if we cut ourselves or if we have an infection. Acute inflammation increases the body's capacity to fight infection and it promotes wound healing. Acute inflammation is a good thing. But if acute inflammation does not subside, we have then a state of what is called chronic inflammation. And it's induced by chronic stress. And we can come back to that. But in terms of how our bodies work, I wanted to identify that chronic stress is not in anybody's interest. Chronic stress lays down those nasty plaques, those fatty plaques that constrict our heart vessels, that constrict our brain vessels and put us at higher risk for heart attack and stroke. Chronic stress raises our blood pressure, raises our heart rate, and it releases in a persistent way, not in a short burst, but in a persistent way, a hormone in the body, a stress hormone in the body called cortisol. And cortisol is not good when it hangs around for a long time. And one of the principal things that it does is that it impairs the body's capacity to fight abnormal cells or viruses, our immune system. It compromises our immune system. And that means not only are you at greater risk to get more colds, you're at greater risk to get cancer, because cancer is about the immune system detecting abnormal cells and killing them before they multiply. So chronic stress is a bad thing, and there's a whole literature also that demonstrates very high associations between chronic stress, this persistent cortisol state, inflammatory state, and conditions like depression, conditions like PTSD, even schizophrenia. And we know it to be also a factor in heart disease, stroke, diabetes. Chronic inflammation eats away at the cells in the pancreas that make insulin and put us at risk for diabetes. So chronic inflammation produced by chronic stress, that's the enemy.
So one of the first things you talk about in that section are adverse childhood experiences, or ACEs. Could you maybe talk about ACEs for a little bit and how they shape us going forward?
If there was one thing as a public health doctor that I would want to see happen in my professional lifetime, is for our health system to identify these adverse childhood experiences in youth, 4 years old, 3 years old, 5 years old, and intervene, particularly with their families, to reduce this, because there are a set of 6 or 8 different what are called ACEs, adverse childhood experiences. They include many foster care placements, neglect, physical and sexual abuse, domestic violence, addiction in the home, and other conditions. And each one of these is additive. So a child with one ACE has got some vulnerability, but a child with 4 or 5 of these, which typically cluster, by the time that child who's exposed when they're young, by the time that child is an adolescent, they have all the indications of chronic inflammation, chronic stress. They are obese. They have what's called insulin insensitivity, the precursor to diabetes, where the insulin in the body is not working very well. They have high rates of depression. They have high rates of suicide. They're smokers. There's a lot of teenage pregnancy in the girls. They already have their bodies are already responding to the consequences of these adverse childhood experiences before they're adults. And these are unfortunately very common problems in terms of those that I described, the ACEs that I described. And there are ways to intervene, particularly by working with mothers, by families, skill building. It's not about psychotherapy for the kids. It's enabling the parents or foster parents or others to develop much more effective parenting skills, to be much more able to provide the kind of secure attachment, to be less blameworthy and much more helpful to the kids in terms of mastering their behaviors. And there are a number of programs like this that really shine. There's one here in New York called Parent Corps. Parent Corps works with inner city underprivileged 4 or 5-year-old kids in school, preschool. There are many other examples of this. It's just that they're hardly present. They work, but they're hardly present. So as a public health doctor, I think that if the one thing we could do more of that would make the biggest difference would be intervening early with those children who we know are going to have very serious problems as a consequence of their early life, and no fault of their own.
Yeah. So you talk a little bit about trauma, and so I was curious to hear some of your thoughts on the best approaches to remedy traumas, and if you had any stories about, patients or other people that use these approaches successfully.
Yeah, the trauma comes in different forms, but its common pathway in the body is the same in terms of chronic inflammation and all of the problems that come with that. But trauma comes when you have kids who are neglected or abused. Trauma comes from war. And we see this as a very common consequence of men and women who have been in combat. We see this in adults who are traumatized. They may be by a physical incident or rape, by people who have forced dislocations from their countries because of terror and violence in their countries. And we see this also in the wake of natural disasters, which I've unfortunately seen and been part of the mental health response, like 9/11, like Sandy, the Hurricane Sandy here in New York, New Jersey, and Katrina, where people lose their homes, they sometimes lose their loved ones. These are all ways by which the body undergoes a profound physiological, cognitive, and actually neuronal changes in the brain as a result of that kind of severe trauma. And of course, the best approaches are prevention, right? Keep this from happening, or if it's happening, intervene early, because like with most conditions, if you get to it early, you stand a better chance of making a difference. Later, it grows deeper roots. So, and the interventions are quite varied. Sometimes they're more a matter of supporting people in their natural responses, which is to go back to work, to go back to living, to form relationships, to have routines in their life, and to not, and progressively get back to what they were doing, because avoidance makes things worse. And in more advanced states of trauma, persistent trauma, there are a variety of therapies, none of which work, none of which are have rates of 80 or 90%. We need to do better there. But for example, with veterans, we have rates of maybe 35 to 40% improvement in combat veterans. VAs, some of them are really good at this. And what they do is provide usually a combination of treatments, comprehensive treatment, certain medications which can help reduce the arousal and help people sleep, quiet nightmares, and certain forms of cognitive therapy, and particularly exposure therapy. That's what's known to work the best with trauma. And what that means is, like for the veteran, to reimagine the trauma progressively in digestible bits, so that over time they desensitize themselves to the trauma. And that can be done by imaging, and in some instances it can be done by putting yourself back in the environment that the trauma occurred, like, for people going back to ground zero, for example. So there are techniques that are treatments. Prevention is the best, early intervention, but even for people with advanced traumatic conditions, there's help to be had.
So building on that, you talk a lot about just the stresses in our own kind of daily lives and what people are dealing with. So I was curious about your thoughts on some of the best strategies for preventing and managing more, I don't want to say routine stresses, but the stresses that many people tend to go through all the time, and how we can implement those strategies for managing stresses on a consistent basis.
Yes,
I think that's key.
I'm really glad you asked this question, because I don't want my message to seem like I'm suggesting to people that because life is stressful, they should just have a small life. I want people to have as big and robust a life as they can have. But that will induce chronic inflammation. It's just the way things are now in terms of the overstimulation, the demands, the expectations that we put on ourselves. We live lives of chronic stress. So if you want to have a big life, you have to think, okay, how do I manage that chronic stress so I can have the big life and not suffer all the unwelcome consequences? And there are a number of things, all of which are free, all of which can be done right now, and you don't have to call your insurance company for prior approval. So for example, things that reduce chronic inflammation in the body: exercise. So most people think, oh, I can't do that. I don't have time to go to Soul Cycle or what, a run by the river or Prospect Park. Exercise is simply 10,000 steps a day, which seems like a lot, but it's not. 10,000 steps, which you can measure on your smartphone, on a Fitbit, 10,000 steps a day does a trick in terms of exercise. Nutrition. Our body doesn't really like a lot of red meat. It doesn't like a lot of French fries. It doesn't like a lot of processed food. But it does like fish and vegetables. Nutrition makes a difference in terms of chronic inflammation in the body. Sleep. Sleep is very restorative, something that eludes many of us, but to the extent that you can, get 7 hours of sleep a night as an adult. Relationships. Relationships actually, these trustworthy relationships also diminish stress in the body. And then there are a variety of mind-body, what are called mind-body interventions, like yoga, meditation, mindfulness, slow breathing. These are techniques that quiet that activated system, often within seconds. And if used regularly, not that you have to do it 20 minutes a day, like I used to meditate regularly, but in recent years I use slow breathing. And it's people who taught me said, oh, you should do this 20 minutes a day or 20 minutes twice a day. And I think, well, that's a good recommendation. I'm never going to do that. But if I'm walking somewhere, I may practice, I may do some slow breathing. In a boring meeting, I may do some slow breathing. Waiting at a light if I'm driving. So I have these little micro episodes of slow breathing during the course of the day. Very easy to learn. So these are mind-body interventions, exercise, nutrition, sleep, relationships. These are all ways by which we can quiet the stress in our body and have the big lives we want.
That's great. And that's great that there are such actionable items that people can really get started on right away.
And you don't have to do all 5, but the more you do, the better.
Yeah. Pick your favorite, maybe. So I think I'll wrap it up. And I like to just wrap up this section, at least, by asking if there's anything else in terms of any lessons or takeaways you wanted people to have from the content of the book that you feel like we haven't talked about yet.
It's not a lesson, it's a aspiration that readers, I hope, will leave reading the book with, which is that we're, as human beings, we're blessed with resilience. We can bounce back. We can actually, we've learned, rebuild neurons in the brain. It used to be thought you can't build new nerve cells. You can. And I've seen here in this city, other cities, you can rebuild neighborhoods. We are a resilient species. And so we can rebuild our lives. We can manage the tough lives that we have had, no fault of our own. But it takes work. It just doesn't happen. But the work is as described. It has to do with relationships, family, support, taking care of ourselves. These are all things that we can do now, that will help us have the resilient lives, be resilient and have the lives we want.
It's a great message. So I like to end with a couple fun questions just to get to know you a little bit better, and then we'll call it a day. Sound good?
Yes.
All right. So Thunder Round, first question. I always like to ask, what's your favorite food and or drink?
Well, the second question is easier. My favorite drink is coffee. I've tried to reduce or quit coffee, but I love coffee, and I have maybe 3 cups a day, sometimes 4. And some of the science that has come out about coffee in recent years has been reassuring to me, that 2-3 cups a day of coffee is good for your health, and it even helps reduce rates of cancer. So that's my favorite beverage, coffee. My favorite foods are ones that aren't so good for my health, so I try to ration them. I love pizza, and I love Southern fried chicken. So I try not to eat those So I put it in a positive way. I try to say, well, once a month, Lloyd, why don't you have some pizza? Once a month, why don't you have some Southern fried chicken, particularly if you're in the South? Not that in New York you can't get some great Southern fried chicken, because you can. So those are my favorite foods, but over time I've come to realize that I sleep better, my body behaves better if I have some fish and vegetables and rice, and tastes very good.
Good. Sounds good. Where is your favorite place you've ever been?
My favorite place is a place that very, very few people know about, where my wife and I go often 2-3 times a year, where I wrote this book. It's a little village, ancient village in the mountains in south central France called Conques, Conques. And it's an ancient village. It's an historic village. It's on this Santiago de Compostela pilgrimage trail. And it's a tiny village with about 90 year-round families. And we go there, and I feel very open and very able in terms of my thinking and my spiritual self in that environment. And I love to go there, and that's where I wrote this book. And then that's where I wrote this past summer another book that's going to come out in a year from now.
Oh, how exciting. You want to plug the book real quick? What's the new book about?
It's a book about psychoactive drugs. It's a
Caffeine.
book. No, it focuses, of course that's a psychoactive drug, and some of them are not so bad. But it focuses principally on the drugs that pirate the brain, like opioids, like stimulants, alcohol, in immodest quantities. And it starts off with the premise that the approaches that we have had, policy and practice approaches for hundreds of years, have proven totally ineffective, yet we haven't gotten off the dime with them. And those are principally to try to control use or access to these substances, build a wall between us and Mexico, or have border interdiction, or buy and bust, find dealers and bust them on the street. And the world spends billions, scores of billions of dollars a year, every year doing this, and it doesn't work. And then the other is to exhort people to say, you shouldn't smoke that stuff, it'll ruin your brain. And with teenagers, all that does is stimulate them to do it, because they like to rebel. So though it starts with the premise that these are been persistent, ineffective strategies, but there are things that work. And if you want to find out what they are, you can read some of the things I've written online over the past year or two, and you will find out when this book comes out, probably January 2018.
All right, I'm looking forward to it. So last question. If you could wave a magic wand and change any one thing, what would it be and why?
It would be what I mentioned earlier, the attention to detection, recognition of these adverse childhood experiences, and intervention, which means mobilizing schools. It means mobilizing pediatric and family practices. It means mobilizing faith-based institutions, so that because that's where the kids are, and that's where the distressed families are, so that these problems are identified, and those become the sites by which families are helped, because they're less stigmatizing, and they're more places that people will go naturally, particularly schools, to learn the kind of skills to be more effective parents, which they want. It's just that no one's helping them do that. That's the one thing I would do. And I'm trying to do that in my day job. It's just very hard to change a whole culture and change a whole way by which practice occurs in this city, state, and country.
Agreed. But thank you. That's a wonderful goal, and I'm glad that we have people like you on it. So that's it. We'll wrap it up. I just want to say thanks again so much to Dr. Lloyd Sederer for being on the show. Improving Mental Health, 4 Secrets in Plain Sight, a wonderful book. Thanks again, Lloyd.
It's great to be here. Thank you, John.
Thanks so much for listening to this episode of Read, Learn, Live. If you liked it, tell a friend and subscribe on iTunes and Google Play. If you hated it, tell a friend and subscribe on iTunes and Google Play. And so it goes.